Diagnostic testing in endocrine diseases. This video will take you through the various diagnostic tests used in an array of endocrine diseases. The diseases covered shall be those encompassed in undergraduate endocrine teaching at the University of Dundee. This video will not cover diseases involving the reproductive aspects of the endocrine system. As such, the following is a list of the diseases covered: diabetes mellitus and diabetes insipidus, Cushing's syndrome and disease, Addison's disease and Conn's syndrome, hypo and hyperthyroidism, and, finally, acromegaly. It is first useful to have a basic understanding of some of the signalling axes involved in the diseases that shall be covered, as monitoring the state of these axes is often essential in their diagnosis. Although this video shall not go into great detail on this, a basic summary will be given over the following minutes to refresh your memory. Nonetheless, it might be useful to go back and look over your own notes on the physiology of these axes in greater detail before continuing to maximise the educational benefit of viewing this video. The table shown gives a brief overview of some of the hormones which are involved in and whose values being abnormal can cause the diseases that will be covered in this video. This might seem quite complex, and indeed, it is. Fortunately, we have summarised this table into simpler pathways in the following diagram. The top row gives the hypothalamic or central hormone involved in the given pathway, while the arrows point to both the pituitary and peripheral hormones that are stimulated. These hormones act on the tissues of the body, such as the heart, liver, adipose tissue, bone, etc., to bring about pre-programmed specific changes within these areas. You can pause here if you wish to quickly overview these axes. Having at least an idea of the physiology of these is very useful as we continue through this video. If you feel comfortable with the basic hormonal axes, then let's get started. Diagnosing diabetes mellitus. Diabetes mellitus is a disease in which the body's ability to produce or respond to the hormone insulin is impaired, resulting in abnormal metabolism of carbohydrates and elevated levels of glucose in the blood. As a reminder, type 1 diabetes results from the autoimmune destruction of beta cells within the pancreas, usually in youth, resulting in total insulin deficiency. Type 2 diabetes is a loss of insulin sensitivity on the back of long-term glycemic stress, typically seen in older, obese patients. Despite the clear differences between these diseases, the diagnostic criteria, for the most part, is the same. The distinction between type 1 and type 2 diabetes will depend upon the clinical presentation. It is important, however, not to simply rule out type 1 diabetes in the patient who presents with the typical clinical picture of type 2 diabetes. At undergraduate level, you will be taught about various other types of diabetes that exist. However, for the purposes of this video, we will focus on the criteria which are in place to diagnose diabetes in general. The first of these is a random venous plasma glucose measurement. This involves taking a sample of the patient's blood randomly when they present to a clinic, and sending it for laboratory testing to determine its glucose concentration. If the patient has symptoms consistent with diabetes, including polyuria, polydipsia, and for type 1 only, unexplained weight loss, and the random blood glucose concentration returns greater than or equal to 11.1 millimoles per litre, then this is likely diagnostic for the disease. Usually, one of the other tests that follow is then used to confirm the diagnosis. If the patient does not have symptoms, and their blood glucose is higher than 11.1 millimoles per litre, then a repeat of the test is carried out. A test that can be carried out after a random blood glucose level suspects diabetes is an oral glucose tolerance test, which is much more reliable than the random blood glucose measurement alone. In this test, the patient is first told not to eat or drink for 8 to 12 hours before their appointment, and their blood glucose is measured upon arrival. This is known as fasting blood glucose. The patient is then given an oral glucose load in the form of 75 grams anhydrous glucose in 300 millilitres of water to be taken over 5 minutes. The patient is kept in clinic for the next 2 hours and is told not to eat or drink once again. After this time period has elapsed, their blood glucose level is tested. The idea behind this test is that the clinician gets to see directly the effect of a known quantity of glucose on the patient's blood sugar level, and, by comparing the results to reference values, can either diagnose or exclude diabetes. In a person without diabetes, the initial fasting blood glucose level should be under 6 millimoles per litre, whilst their blood sugar 2 hours after taking the glucose should remain under 7.8 millimoles per litre. For a person with diabetes, their initial fasting blood glucose level would be seen to be over 7 millimoles per litre, with a blood sugar after the glucose tolerance test of over 11 millimoles per litre. This test can also distinguish patients into one other group, those with impaired glucose tolerance. These patients will likely have a fasting glucose level slightly higher than normal, between 6 and 7 millimoles per litre, with this measurement sitting between 7.9 and 11 millimoles per litre after glucose tolerance testing. This group of patients is important to keep in mind, as they are likely on the pathway to developing diabetes, and as such, any risk factors such as poor diet and obesity should be addressed early on to help prevent further progression. Over recent years, a new method of diagnosing diabetes has emerged and is now very much widespread. The HbA1c test, or glycated hemoglobin test, measures the degree to which hemoglobin in the blood has been glycated. In other words, it measures its degree of exposure to high blood glucose levels over a longer period of time. Although perhaps more useful in monitoring diabetes, the World Health Organization now advocates the use of HbA1c diagnostic testing in type 2 diabetes. It should not be used for diagnosing type 1 diabetes. There are also a few confounding factors, which can lead to falsely high or low HbA1c levels that clinicians should keep in mind, such as hematologic conditions which affect hemoglobin levels. In this test, a sample of blood is again taken from the patient, with no need this time for prior fasting, and is sent to the lab. Results were previously given as percentage glycated hemoglobin, but it is now recommended to give HbA1c values with units of millimoles per litre. A HbA1c of less than 42 millimoles per litre is considered normal, and diabetes is excluded provided that the glucose tests previously mentioned are also within the normal range. If the HbA1c result comes back between 42 and 47 millimoles per litre, the patient is described as pre-diabetic. This is the group of patients we mentioned earlier, who are further along the pathway to full-on diabetes. Finally, a HbA1c result of greater than 48 millimoles per litre is diagnostic of diabetes. These values in the longer term are very useful in monitoring a diabetic patient's response to a new drug, their blood sugar control in general, or in determining whether or not a patient is actually compliant with their drugs. We are sure you will agree that that's enough on diabetes for one day, so let's move on to the next disease. Diagnosing diabetes insipidus. More diabetes? Don't worry, diabetes insipidus is a very different disease to diabetes mellitus, so your brain will have a rest from the word glucose, at least for now. In fact, the word diabetes actually originates from the ancient Greek, meaning to siphon, relating to the polyuria and polydipsia seen in these diseases. Diabetes insipidus is a disease in which the body either fails to secrete or fails to respond to the hormone ADH, or antidiuretic hormone. As such, the body fails to regulate the excretion of water, and large volumes of dilute urine are produced, often leading to dehydration and extreme thirst. ADH is normally released from the pituitary in order to prevent the loss of water in the collecting tubules of the kidneys. Patients with diabetes insipidus may either produce ADH, but their kidneys do not respond to it, nephrogenic diabetes insipidus, or may not produce ADH at all, central diabetes insipidus. If for a moment we think of the pituitary as a television broadcasting station and the kidney as a house, we can create an easy-to-remember analogy as to the reason for these two types of diabetes insipidus. If the television broadcasting station's transmitter breaks and it cannot distribute a signal, then even if the house has a satellite dish, it will not receive the transmission, much like in central diabetes insipidus, the signal representing ADH, which is not being produced. Likewise, if the television station is broadcasting the signal, but the house does not have a working satellite dish, it will be reached by the signal, but will have no way to translate it into something meaningful, with this representing nephrogenic diabetes insipidus, where the kidneys do not respond to ADH's signal. The diagnosis of diabetes insipidus involves a test called a water deprivation test. The patient's urine is first tested for the presence of glucose in order to rule out the possibility of diabetes mellitus, as this is an important differential initially in the frequently urinating patient. Having done this, a water deprivation test is carried out. The patient is deprived of water for 12 hours. During this time frame, their urine output, blood electrolyte levels, and weight are frequently assessed by the clinician. The test is stopped before 12 hours has elapsed if the patient has a decrease in blood pressure an increase in heart rate, or a loss of more than 5% of their initial body weight. The patient is then given an injection of vasopressin, and their response monitored. A diagnosis of central diabetes insipidus is made if, following this injection, the patient's excessive urination stops, their urine becomes more concentrated, their blood pressure increases, and their heart rate normalises. A diagnosis of nephrogenic diabetes insipidus is made if the injection of vasopressin does not cause a change in the patient's readings. Diagnosing Cushing's syndrome and disease. The first thing that is important to understand here is the difference between Cushing's syndrome and Cushing's disease. The definition of Cushing's syndrome is as follows: a metabolic disorder caused by overproduction of corticosteroid hormones by the adrenal cortex, and often involving obesity and high blood pressure. In other words, the syndrome is simply a state of having too much corticosteroid, regardless of the cause. Cushing's disease, on the other hand, is Cushing's syndrome caused specifically by a tumour of the pituitary gland. It is important to note, therefore, that these are not distinct and different conditions, but that the syndrome is more general, whereas the disease is a specific subtype of the syndrome. Keeping that in mind, let's look at diagnosis. The patient might be asked to collect urine for 24 hours initially, as the elevated presence of cortisol in the urine is suggestive of Cushing's syndrome. If 2 of these tests are carried out and the syndrome is indicated, the gold standard method of diagnosing Cushing's syndrome, the low-dose dexamethasone suppression test, is carried out. There are 2 variations of this, the first being more commonly used in lower probability patients. In this variation, called the overnight low-dose dexamethasone suppression test, the patient is given a 1 mg dose of dexamethasone to be taken at home at around 10 p.m. Blood samples are then taken from the patient the next morning at around 9 a.m. Elevated levels of cortisol in the blood suggests Cushing's syndrome. More specifically, in a normal patient, the cortisol level is expected to suppress to less than 50 nanomoles per litre. The second variation is the 48-hour low-dose suppression test. In this test, the patient has their baseline blood cortisol measured at 9 a.m. on the first day of the test, as well as taking a 0.5 mg dose of dexamethasone at the time. They then take a 0.5 mg dose of dexamethasone 8-hourly for the next 48 hours at home. At 9 a.m. on day 3, 8 hours after their last dose at 3 a.m, the patient's blood is tested once again. If the blood cortisol level does not suppress to less than 50 nanomoles per litre, this is suggestive of Cushing's syndrome. However, as you might have figured out, neither variation of this test really indicates to the clinician the cause of the patient's hypercortisolism. Rather, it just shows that they are exhibiting higher than normal levels of cortisol. Fortunately, the clinician can carry out a further test to distinguish between the causes of the lack of cortisol suppression. A high-dose dexamethasone suppression test, usually carried out under admission due to the higher risk of side effects, follows the same protocol, but instead using 2 mg doses of dexamethasone. If the cortisol level does not suppress at low dose, but does suppress at high dose, this suggests the pituitary still maintains some feedback control, and so this is more likely to be Cushing's disease. In these patients, the blood ACTH level can also be measured and will be normal to elevated. If a high dose does not suppress the level of cortisol, this is not likely to be Cushing's disease, as the cortisol is clearly being produced independently of the pituitary. In these cases, the ACTH level would be undetectable or low due to the excess cortisol suppressing the pituitary. Interestingly, some patients are Cushingoid as a result of an ectopic ACTH-producing tumour. In these cases, the cortisol level will not suppress at either dose of dexamethasone, and the blood ACTH level will be elevated hundreds of times beyond normal. Diagnosing Addison's disease. Addison's is a disease characterised by progressive anemia, low blood pressure, great weakness, and bronze discoloration of the skin. It is caused by inadequate secretion of hormones by the adrenal cortex, or in other words, adrenal insufficiency. In suspected cases of Addison's disease, demonstration of low adrenal hormone levels, even after appropriate stimulation with synthetic pituitary ACTH hormone, is needed for the diagnosis. 2 tests are performed, the short and the long test. Dexamethasone does not cross-react with the assay, and so the patient does not need to stop taking this before testing is carried out. The short test compares blood cortisol levels before and after 250 micrograms of synacthin is given. If, 1 hour later, plasma cortisol level exceeds 170 nanomoles per litre and has risen by at least 330 nanomoles per litre to at least 690 nanomoles per litre, adrenal failure is excluded. If the short test is abnormal, the long test is used to differentiate between primary adrenal insufficiency and secondary adrenocortical insufficiency. The long test uses 1 mg of intramuscular synacthin. Blood is taken 1, 4, 8 and 24 hours later. Normal plasma cortisol level should reach 1000 nanomoles per litre by 4 hours. In primary Addison's disease, the cortisol level is reduced at all stages, whereas in secondary corticoadrenal insufficiency, a delayed but normal response is seen. Diagnosing Conn's syndrome. Also known as primary hyperaldosteronism, Conn's syndrome is a condition characterised by overproduction of the hormone aldosterone by the adrenal gland, leading to excessive salt and water retention in the kidneys, and thus high blood pressure and abnormal electrolyte levels. Measuring aldosterone alone is not considered adequate to diagnose primary hyperaldosteronism. Instead, both renin and aldosterone are measured, and a resultant aldosterone to renin ratio is calculated for case detection. A high aldosterone to renin ratio suggests the presence of primary hyperaldosteronism. The diagnosis is then made using a saline suppression test. In this test, the patient is infused with 2 litres of 0.9% saline intravenously over 4 hours, essentially acting as a salt and water load. At the end of the test, if serum aldosterone is greater than 140 picomoles per litre, then a diagnosis of primary hyperaldosteronism is confirmed. Diagnosing thyroid disease. Compared to the preceding diseases, the diagnosis of thyroid disease is, fortunately, quite a bit simpler. The two main disease states that we are going to look at are hyper and hypothyroidism. In hyperthyroidism, or an overactive thyroid gland, patients present with symptoms including excessive sweating, a fast heart rate, palpitations, weight loss, and heat intolerance. On the other hand, hypothyroidism causes patients to experience the opposite of these, a slow heart rate, weight gain, and cold intolerance. To diagnose these, blood tests are carried out on the patient to measure their levels of TSH, or thyroid stimulating hormone, T3, the most biologically active thyroid hormone, and T4, or thyroxine, the most abundant thyroid hormone. In primary hyperthyroidism, the levels of T3 and T4 would be expected to be high, whilst the TSH level would be low due to negative feedback inhibition. In primary hypothyroidism, the levels of T3 and T4 would be expected to be low, whilst the TSH would be high, as the pituitary tries to correct for the low levels of hormones produced by the poorly functioning thyroid gland. Diagnosing acromegaly. The final disease we are going to cover the diagnosis of in this video is acromegaly. This is a condition characterised by abnormal growth of the hands, feet, and face, caused by overproduction of growth hormone by the pituitary gland. Diagnosing this disease involves 2 key tests: a test to measure the concentration of insulin-like growth factor 1, IGF-1, and an oral glucose tolerance test. The reason why IGF-1 is measured, rather than measuring growth hormone itself, is that its levels are much less fluctuant, and as such there is much less scope for false positives and negatives. An elevated level of IGF-1 is suggestive of acromegaly. The oral glucose tolerance test for acromegaly should not be mistaken for the test that is used in diabetes mellitus, although similar. In testing for acromegaly, a baseline blood glucose and growth hormone sample is first taken, and the patient is then given 75 grams anhydrous glucose dissolved in water. Over the next 2 hours, at 30-minute intervals, the level of growth hormone and glucose in the blood is measured. In a normal person, it would be expected that the increasing presence of glucose in the blood would suppress the production of growth hormone. If growth hormone does not drop below 1 nanogram per milliliter, the patient has acromegaly. Summary of learning. To summarise, this video has taken you through the various diagnostic tests that are used across the endocrine discipline. Of course, this is something that needs to be looked back at occasionally in order to keep the reasons for each test fresh in the mind. You could, for example, now simply use this video as a reference tool in order to remind yourself of how a certain disease is diagnosed. Although not covered in this video, it might be useful to now couple your learning here with some of the treatments for the diseases that have been covered. Thank you for watching.